Hello everyone, let's discuss some unusual carotid artery disease circumstances. So if there is a patient with IC occlusion, that is internal carotid artery occlusion, usually it can be left alone and no treatment is recommended. Some patients with IC occlusion can continue to have stroke or symptoms of stroke on the similar side. That can be related to stump syndrome. In that case, you need to ligate the internal carotid artery and do an endarterectomy of the external carotid artery along with the common carotid artery. In patients with carotid dissection, which is common in patients sometimes with blunt cerebrovascular trauma, antiplatelet therapy is the treatment of choice as long as the dissection is non-flow limiting. In patients with flow limiting dissection, open as well as endovascular treatment are options. An interesting scenario is patients who have carotid artery stenosis along with coronary artery disease. In those patients who are symptomatic with carotid stenosis, a carotid endarterectomy before a CABG or with the CABG surgery is recommended. Another important thing in patients who are symptomatic and haven't had an acute stroke. If the stroke is less than 6 hours, local or systematic thrombolysis is recommended. Once the patient has a stroke, it is recommended that carotid artery surgery be performed within 2 weeks after the stroke. That is when the symptoms of stroke have plateaued and stabilized. If the patient continues to have repetitive strokes, that is crescendo stroke, an urgent/emergent carotid endarterectomy is the treatment of choice. Another important thing to know, after a carotid surgery, that is either a CEA or stenting, if the patient has an acute stroke post-op, stat ultrasound, as well as take the patient back to the operating room for surgical exploration of the carotid is recommended, because most likely the cause of the recurrent stroke post-op is technical. Thank you.